This echocardiographic study of a 57-year-old man presenting with chest discomfort. As seen here, there is a large mass in the right ventricular outflow tract. It is important to note that a large mass in the right ventricle or its outflow tract isn't always a primary RV tumor. Sometimes it can be a structural abnormality that mimic a mass. Now let's review some common RV masses that can appear quite large. Thrombi are the most frequent RV mass and typically occur in the context of the RV dilation or dysfunction, the presence of an indwelling catheter or pacemaker lead, a hypercoagulable state, or venous thromboembolism. The second most common RV masses are tumors such as myxomas, lipomas, angiosarcomas, or rhabdomyosarcomas. Metastases such as those from lung or breast cancer, melanoma, renal cell carcinoma, or lymphoma should also be considered. However, it's important to keep in mind that some non-neoplastic mimickers can also appear in the right ventricle, such as a sinus of Valsalva aneurysm or a ventricular aneurysm. This right peristernal view shows a large mass connects to aortic root. Now let's explore the transesophageal echocardiographic views. In this view, we can see a large mass occupying most of the right ventricle, but it's actually a large cyst-like structure containing clots with swirling blood flow which originating from the right coronary cusp. Indeed, this is a large sinus of Valsalva aneurysm with a severe smoky pattern and multiple clots. A sinus of Valsalva aneurysm is an outpouching of one of the aortic sinuses located between the aortic valve annulus and the sinusoidal junction. It most commonly originates from the right coronary sinus, followed by the non-coronary sinus and rarely the left. As the sinus dilates, it can bulge into adjacent cardiac chambers such as the right ventricle, right atrium, or even left ventricle, potentially causing mass effect, obstruction, or even rupture into those chambers. This is aortic insufficiency caused by changes in the geometry of the aortic annulus, its continuity with the aortic sinus, and the dynamic changes during the cardiac cycle are key in differentiating it from other cardiac masses. In the event of rupture, there will be flow from the aneurysmal site into adjacent chamber, and this will appear as negative contrast on imaging. The absence of negative contrast in the right ventricular outflow tract here indicates that the aneurysm has not ruptured. It is noted that a sinus of Valsalva aneurysm can serve as a nidus for thrombus formation, and the presence of clots within the aneurysm increases the risk of systemic embolism and can also complicate surgery. This CT scan shows that the aneurysm occupies most of the right ventricle, and this is a large clot within the aneurysm. This echocardiographic study performed after surgery shows no residual aneurysm. In conclusion, when a mass is seen in right ventricle, could this be an aneurysmal sinus of Valsalva?